Hi there, good afternoon. I'm Susan Canaveri, and I am on the board of the CMT Research Foundation. And I am delighted to introduce Ken Cornell, who is a certified orthotist.
Good.
He's with Cornell Orthotics and Prosthetics. Ken is a certified orthotist and co-owner with his twin brother of Cornell Prosthetics and Orthotics, based in the greater Boston area. And he's got the job with the biggest tongue twister of anyone. Ken has taken a keen interest in CMT. Ken is attending orthotist at the CMT clinic at Massachusetts General Hospital. He is such a CMT expert that he's often called to conduct educational seminars about CMT to his fellow orthotists, and is only one of the few who are highly favored by the CMT community. Ken's secret to success with CMT is his credo: take time to listen and understand, then formulate a plan to make a greater improvement than expected. Ken focuses on finding practical solutions with people with CMT, solutions that people will use, wear, and thrive in. His least desired outcome is to build a pair of orthotics that end up in their closet. And I have to tell you that Susan Rudiger sent me a long email of all of the reasons why she loves Ken. And I know that she would have wanted to be here today to introduce Ken herself. So on her behalf, I just want to thank you very much for being here.
Thank you, Susan. Appreciate
Thanks.
it. Hi, everybody. Very nice introduction. Thank you very much. These aren't going to clash. That's good. So hopefully we'll have some fun today. Hopefully I don't go too long. But I thought of myself, when I was asked to do this presentation, what would I want to know coming here as a patient, to this meeting? And I know a lot of this stuff is very scientific and stuff. And this is what I really thought would be nice if everyone, sorry. Okay. I'm on. Is what to expect from AFOs, And so we all know what we can expect when we get a car, right? You get a car, you know what size it is, all the options, it has a moonroof, GPS, engine size, miles per gallon. You know a lot about the car, you know what to expect. When you get a cell phone, same thing, right? You know the screen size, the storage, the battery life, it has a camera, it's the size you want, what type of phone you get. Trip to Disney World, the flight you're taking, the hotel character breakfast Friday morning, and the picture with Minnie Mouse. Are we good? So why should our expectations for AFOs be so less clear? Oh, thank you.
They just want to see your smiling face.
Oh, they got me? Hi, everybody. So in my experience, patients come to my office and the expectations range greatly as to what they expect from AFOs. And most of them are low. People come in, they say, geez, I really have no expectations at all. What are the AFOs going to do? It may help a little with walking or tripping or falls or ankle sprains. Occasionally, I have patients with very high expectations. I want to walk like I don't have CMT. AFOs should be invisible. They should weigh nothing and take up no room in my shoes. They should cost nothing and require little or no maintenance or follow-up. And that doesn't happen very often. But the whole idea is to avoid disappointment. We want to make expectations clear. So today we're going to clarify what you should expect from AFOs if you have shock-and-wave tooth disease. And there are some terms you become familiar with. And I know if there are physicians in the room, these are very simple terms, but for patients, I just want to go over, we're going to talk about human gait, dorsiflexion, plantar flexion, eversion, propulsion, and proprioception. Because you need to understand those concepts to know about bracing. And I love this slide. I could watch this slide over and over again. This is basically how what's called an inverted pendulum moves a mass over a distance. You got to watch this again. This guy's going to run, jump, and this is the inverted pendulum, and he's the mass, and it's being moved over a distance. And this is called canal jumping. They do it, I guess, in the UK. And this guy had to have won. That was a really good jump there. We're going to talk about why that's important down the road. Human gait, normal human gait is very complicated. And if you ever gait studies, they're very complicated, a lot of math. We can talk about the basic elements of human gait. This is a nurse that I work with at the hospital. She's a phenomenal walker. She is the fastest one to get to a nurse stat call. And I actually put a gait belt on her, and we got a lot of gait lab data for her. But, you know, in general, human gait is tremendously efficient pattern. We have a tremendously efficient gait pattern. And if you look at her, her walking speed is pretty good. She gets great propulsion. She has great pelvic motion and her head barely moves. And that's important. When we're walking, all of our motion should take place in our pelvis, and our head and shoulders should stay very still. And, you know, she has a natural, comfortable arm swing when she walks. We're going to talk about that's important. And also she's able to look around while she's walking with confidence. And how many people in the room have CMT? So how many of you have a lot of confidence walking around? And not so much. Yeah, not so much. And that's really important. So we're going to talk about that. And when we talk about human gait, we break it down into phases. When we're walking, when the leg is swinging through the air, we call that swing phase. When we're walking over the foot, that's stance phase. And in swing phase, we're basically looking for a toe clearance. We don't want to drag your toe and trip over your toe when you're walking. And in stance phase, we're looking for these three specific rockers. And basically, we want to see heel strike, then the foot going down to the floor in a controlled fashion. Then with the foot fixed on the floor, we move over the foot. We call that second rocker. And then prior to heel strike of the leading foot, we should get heel rise. And that's really important. We're going to talk about that next. But with CMT, we don't have natural, normal human gait. What we have is compensatory gait. And any gait compensations that they make up for all our deficits. And you can see Mark over here walking, not nearly like that nurse was in the earlier picture, right? It's these deficits are due to weakness and sensory loss, limited joint motion, you know, that tight Achilles tendon that people get. And sometimes you can't invert the foot normally to get it to normal motions, skeletal deformities and pain. Compensatory gait is always less efficient, as Mark is demonstrating very nicely here. Notice the downward gaze. We're going to talk about that. Downward gaze because when you're looking down, when you're walking, you know, the slightest little pebble could make you lose your balance. And so we look down to make sure nothing bad happens, right? He has a lot of upper body sway. He's got that steppage foot drop and a very guarded gait pattern. He's very guarded when he walks too. He has pretty good skeletal alignment though, overall. That's one good thing that Mark has going for him here. Dorsiflexion. Dorsiflexion is the motion. It's basically requires muscle strength. And these muscles here in the anterior compartment, we call the very front of the leg, is where these muscles are. They're not very many of them, and they're very small. And what dorsiflexion does is it brings our toes up so we can clear the toes in swing phase. It also lengthens in the stance phase to slowly lower the foot down to the floor. And we can see how strong it is just really having somebody walk on their heels quickly. And if they can walk on their heels or tap their toe, they get pretty good dorsiflexor strength. Plantar flexion is the opposite. Plantar flexion are all these big bulky muscles in the back of the leg. And that's, again, motion that requires muscle strength in the posterior compartment. And this pulls the foot and toes downward and raises the heel up so that we can walk on our toes. These muscles are very strong. My ballerina show up? Yeah. Ballerina can get up and stand on her great toe. By the way.
Something I can't do. And but one thing I can do is help some folks out here online real quick. So
Thank you.
let me do one thing for our folks online.
Sure.
There we go. Perfect.
Better? Thank you. Hi, everybody online. So again, plantar flexion allows us to get up on our toes. And we're going to talk about how important that is a little later. Next slide. We're going to talk about eversion. Eversion is that ability to move the foot out to the side, laterally away from the midline. And again, same thing. It's motion, and it requires muscle strength. And this is in our lateral compartment. So here you can see it's color coded. The red is our anterior compartment. Those are the muscles that pick our toes up. The purple over here, or the blue, is the everters that basically pull the foot out to the side. And in the back are the big purple and green back here, or rose color and green back here. And they're very powerful muscles that pull our foot down. Imagine all these muscles are in their own little like cellophane bag. Okay. And those are the three compartments in our lower leg. They're all innervated by different branches of the nerves. They all get affected at different rates. And so there's a very specific sequence of muscle loss that occurs with patients with CMT. Propulsion. This is my nephew Isaac running on the ice in Maine and very propulsive. You know, what gives him that propulsion is, so 70% of our propulsion comes from our ability to get up on our toes. That's why that's so important that we can get that heel rise when we're walking. Achieving heel rise, plantar flexion of the trailing foot just prior to heel strike of the leading foot is what gives us 70% of our propulsion. Also note the way his arms are swinging, right? Arm swing is really critical too. When we run, we swing our arms. And a soldier will always walk swinging his arms too to get more power. And we're going to talk about that a little later when we talk about gait. But what happens if you don't have good propulsion? You have fatigue. And how many of you have a complaint that you just get fatigued way too early? Yeah. And typically that comes from the ability to lose your propulsion because you're not getting good plantar flexion of your foot and heel rise when you're walking. Balance. Everyone raise your hand, just say balance. Yeah, right? Balance, right? I had one patient, I remember he came to me, he was an attorney. He was 6'4". He was a litigator, he'd be in court. And he would stand up in front of the judge and turn to the jury, then turn to his client and lose his balance and fall. And he was defending a drunk driver. And he said, you know, the foot drop's a nuisance. This is that. My ankles are like a nuisance. I don't want to ever fall in court again. Balance was really important. And so there are some requirements for balance. The first one is muscle strength, right? As we lean forward, we need the muscle strength to center our gravity back over our foot. And if we lean back, we have to pick our toes up to basically do, these are our righting reactions. Without that strength, we can't do that. And there are 3 sensory components. Vision helps with balance tremendously. That's why the police always say to close your eyes to see how really bad your balance is. Then you have that vestibular function. That's anyone who's played pin the tail on the donkey knows what that is. You spin somebody around and then ask them to walk across the room and you interrupt the fluid in your inner ear. And that can cause dizziness and balance problems as well. The fourth is what we're going to talk about, proprioception. We're going to go into that in a minute. But balance is basically managing our weight line. We have to keep our center of gravity over the base of support, just like this person's doing right here. She has her center of gravity balanced nicely over her base of support. And then you can balance. It's physics. Proprioception. Basically, it's position sense. And it's a requirement for balance. It's the ability to know where a body part is in space and how it's moving relative to the rest of the body. People with CMT, of course, the real name for Charcot-Marie-Tooth disease is hereditary motor sensory neuropathy. This comes under the sensory component of that. And with this sensory loss, the information from our muscle spindle fibers, I don't want to get too technical, but all our muscles have these little organelles called muscle spindle fibers. Their job is to send information back up to our spinal cord and brain to tell us the exact length of any muscle at any time, every muscle fiber at any time. And then your sensory cortex puts it all together like a great big constantly moving jigsaw puzzle so that we know where everything is. It's amazing. But with CMT, what happens is those nerves that send the information up there, down on your feet and come up, never get there. And so we lose our proprioception and balance. I noticed that all my CMT patients and my neuropathy patients in general, whenever I ask them to walk, and I do a lot of that in my office, they'll just walk across back and forth. They all tend to walk to a destination, you know, and then they'll just make contact with that destination. Just hang on to it. You know what I'm talking about? How many of you guys walk to a destination and just will casually, yeah, all of us, right? Casually, we'll just lean against something, you know?
If I look around my house, there are marks on the walls. All over. Just going to a separate wall to get my perception.
Exactly. To get your balance, you've got to maintain contact with a stationary object. So CMT patients are balance challenged with muscle weakness and proprioceptive loss. And how do we compensate? Well, we can walk to a destination and subtly maintain contact with a stationary object. We can put a finger on the wall. We can hold on to a spouse or put your back against a bush or knee against a coffee table. We're going to use that example in a minute. Also, skiing is a great sport for CMTers because they have a ski boot, which is attached to a ski, and that offers an amazing amount of what we call ground reaction, which is what helps us compensate for loss of proprioception. Ground reaction. Ground reaction. In a skier, imagine you're in a ski boot locked in, click, click, right? And the skis are on the ski boots and you try to lean forward. Well, the ski boot holds you back and holds you up. And that's what we call ground reaction. And that will.
I've been afraid to go skiing because I thought there would be a horrible experience, but you're telling me there would be actually better.
I have skiers that literally compete on a regular plane with non-CMT people. Skiing is a great sport for us as CMTs, yeah, because as long as you can fit in a good ski boot, you know, a lot of deformity, yeah. Because the weakness and the distal weakness and that proprioceptive loss is negated by the equipment.
But so that kind of cancels out the balance issue.
Yeah.
On a firm platform.
That's where I'm going with it. Wearing a ski boot is just like putting a finger on the wall. Only instead of your finger telling where you are, you're leaning into the boot and the top of your shin tells you where you are. You lean in, you feel the resistance because CMT is a length dependent neuropathy. And it affects us more distally by our toes first, and then it works its way up. So long as we have what we call 2-point discrimination or up here on our front of our leg, then you can really benefit from ground reaction from an AFO or a ski boot or leaning against a coffee table to know where you are in space. Yes.
Is an inline skate boot or something similar to that or not?
No, well, the ski boot is better because it's more rigid and it doesn't move. A skate is going to be all over the place and yeah. But when you're skiing, it's all about managing your weight line over that base and letting the boot and the ski do the work. And actually, if you wear AFOs, CMT patients, and you're both learning to ski for the first time, you and your friend who have never skied before, I'll bet the CMT guy who's used the AFOs before will learn it quickly or more quickly because he knows what it takes to move his center of gravity to feel where he wants to go. I think it's great, yeah.
I found that I describe as going somewhere without even trying.
Yeah.
Because you don't have to lift your feet up, you don't have to do anything like that.
Are you a skier?
You haven't given us the opportunity to come in yet.
That's great. So let's identify some really specific, things that affect gait for CMT patients. And CMT is progressive. Everyone's in a different place, it seems, with it. And some of these symptoms or all of them. Chuck here, who's doing back and forth, he's actually been wearing AFOs for years. He's getting fit with a new pair. So his confidence is kind of high for the deficits he has, because he basically has foot drop. He has lateral ankle instability. He has very poor balance. He suffers from fatigue. He doesn't have the painful hierarchies and calluses. He has hammer toes. Here he is trying to balance, and he's going to lose his balance. And he lacked confidence. He actually owns a machine shop, and he used to get on the floor to go talk to somebody. And first of all, everybody heard him coming because he slapped as he walked. And secondly, if someone tried to talk to him and he was in open space, he couldn't even concentrate on what they were saying because all he could think about is maintaining his balance. With the AFOs, he says now he's like a ninja walking down to the place and he sneaks up on people.
No,
Now this has some audio to it. So this is my friend Ian. Ian is type 2 chakra range disease.
your surgery is started. So like that, which is the least degree of that,
So straight surgery.
so you know, it's like the hammer toes.
Yeah.
Second set up to all 5. He's also has child.
Nice. You need to get that.
Yeah. That's good.
Orthopedic surgeon who was very good actually today. Transfer.
No, I don't have that.
No,
Osseous space
No.
and
Jeffrey used to.
transferred it.
For his
Well, that's
surgery.
why he had his surgery.
Mhm.
It's,
Also, osteotomy takes some of the varus out of the ankle. Since then, this foot is no longer has any lateral stability. If anything, it has a little weak instability. This side here. still a little hint of lateral instability. Okay, Ian, come on over. So without the AFOs, the downward gaze. And just go back and forth a couple times if you would. A lot of lateral trunk bending, back and forth. Foot slap, a lot of lateral trunk motion. No propulsion. Yeah. No propulsion. Yeah.
This is hopefully before the surgery.
Oh, yeah. No, this is after the surgery. Yeah. Okay, go ahead. Now he's in AFOs. Ground reaction, dynamic carbon AFOs. One more time. Propulsive. He's got some propulsion back. He has great walking speed, right? Look at the confidence. He's not looking down anywhere, he's looking where he's going instead, right? There you go. Actually, put your hands on your hips. Nice balance. Much better. Eyes closed. No problem. Solid as a rock. Solid as a rock. Groovy. Thanks so much. So Ian did really well with those, and that's typical of the patients that I see when they, yes.
I just have a question, I have a thick 4J type, which is different because all these cases are basically based in 1A, which is kind of bilateral, right? And I have a single right side presentation, I would say.
Right.
But actually like a foot drop, So how does it work, for, how does it?
Yeah, with 4J, yeah,
The balance, because I have a mixed picture,
yeah.
here that it's not completely the way it is in 1A, which is,
Yeah.
I have a certain balance, but not all.
I would love to, if you could hold that question, I would love to talk to you after the presentation, because I really want to talk to you about it. I just did a presentation on 4A last year, and which is because it's such a rare thing. Every time I see a 4J patient, I see I want to meet this person. But I'd love to talk to you afterwards.
Everybody told me the same.
Yeah, that's true.
Okay, very good. Okay.
All right, thank you.
Sorry
So,
for interrupting you.
no, that's fine. So, that was a great result for Ian. But the question is, what can you expect? Everyone's different. And it depends upon your specific motor, sensory deficits, and skeletal limitations. And there's a quick CMT 1-minute self-exam, I call this. And basically, the first thing we're looking for is your alignment. Stand up in a mirror, right? And maybe even somebody can look from behind, this looking behind, and look at the alignment of your foot under your weight-bearing line or under your knee. And in the middle, this is perfect alignment right here. Nice and straight, everything's beautiful. In the green on either side of that is normal amounts of valgus and varus in the ankle. And if it's manually correctable, that's a wonderful thing. Because this now is an abnormal amount of valgus at this ankle, and that person's gonna have a plano valgus, flat-footed presentation. And then over on the other side is equino varus, right? And that varus is when you have a high arch, more classic. 75% of CMT people have a high arch foot, 25% have a flat foot. And you want to look at that alignment. And if the alignment doesn't come back to neutral easily, then that's a problem. Can you walk on your heels? Can you walk on your toes? Strength. Can you stand still in open space? Look up at the ceiling and just track a plane going over your head like that. So that's the quick 1-minute self-exam. If you failed all 4 test questions, but you have no fixed deformity, you have no proximal weakness, and no other limiting conditions, then here's what you can expect. We can expect that you can restore the basic elements for normal gait with AFOs. AFOs will restore all those basic elements. I'm going to repeat that because it's really important. If you fail all that test questions, you can basically get the basic elements of normal gait restored with AFOs. We can restore your propulsion for better gas mileage and less fatigue. We can increase your walking speed. We can restore your confidence again, which we're going to talk about, and restore your static balance. That's what you should be able to expect from your orthotist when you get home, okay? And say, I have CMT, I have these deficits. This is what I expect to get back now. And that's sort of like the trip to Disney World. And how do we fix balance with CMT? Well, this is my friend Mark again. Yeah, so hang on to the bar, like you're pretty straight.
balance. Not like both bars. Lower your center of gravity. And hang on. Lay out if you close your eyes. Okay, good. All right. Hang on to the bars.
All right, and now this AFO he's wearing here is for maximum ground reaction. It's a solid ankle ground reaction AFO, and it's designed to act like that coffee table. He leans into it, he can feel the resistance, and it's like having a finger on the wall. Let's see how well it works. And it's just on his right leg.
Okay, so hands on your hips. No problem. Stay in the rock.
Watch his knee on the
Nice
side.
close.
Now he's looking for the brace.
Myself. Looking for. Hey, you don't have to crouch. No, 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 don't have to crouch. I don't feel like you're gonna. Definitely. Could you pass 20 seconds with no error? That's great.
So it works really well. Okay, ground reaction can really work to restore static balance. It works so well that I actually started a study that we did a year and a half ago, I think, back at the Mass General Boston Center of Excellence, CMT Center of Excellence. And we submitted a study, it finally got published because everyone got the same better results. All their balance improved by using ground reaction AFOs. So it works. Just got to convince Medicare to pay for it when that happens. And all these AFOs, everyone, what kind of AFO you're wearing right now, I'm sure it all takes care of the foot drop and swing phase. Every AFO does that. Swing phase isn't the issue. What really makes these AFOs really valuable is it happens in stance phase. I say, oh yeah, baby, all right? And we're gonna talk about those rockers again. By the way, does this look familiar? Remember that guy canal jumping? The pole, right? This leg is the pole. Okay, and it's moving his center, moving our mass over a distance. It is tremendously efficient when it's done normally. Okay, when we have all these three rockers in place, we have very efficient walking, just like that nurse who walked in the beginning. She was terrific, right? And so this is what we want to restore. We want to restore this first heel rocker, which is again, the foot hits the ground, and then the foot, you can control plantar flexion of the foot down to the floor, not a slap. Right, but a nice controlled motion. This also gives a little bit of propulsion because we're rocking over a lever. Second rocker occurs when the foot's fixed on the floor and now we're advancing over the foot. And again, that third rocker, that's all important third rocker, that we achieve heel rise prior to a heel strike of the leading foot. 70% of your propulsion comes from the ability to do that. And that's what gives us all our power when we walk and all our propulsion. And now, what to expect from this design here. I don't know how many people have ever started. This is usually a brace people start with a simple posterior leaf spring design. But in stance phase, it's really not going to give you a lot of ankle stability if you get varus or valgus instability of the ankle. It's not designed for that. It is very good at restoring first rocker and second rocker, but it doesn't have the strength to pick up your body weight for third rocker. So if you can't walk on your toes, this is not the brace for you. This is just if you can't walk on your heels. And as far as ground reaction for proprioceptive loss, it's not there. It's too flexible. So this brace would be great for somebody who just had foot drop, but the disease process hasn't progressed to the point where they have really poor balance or they still have no propulsion. This is the most commonly prescribed AFO, type of AFO that the insurance companies pay for. It's an articulated AFO, has ankle joint in it with a plantar flexion stop. And unfortunately, this design here does very little for CMT patients. It gives some ankle instability, but it eliminates first rocker, second rocker, and third rocker and offers no ground reaction for balance. So this most commonly prescribed and fit design doesn't do much for CMT patients.
So it's a waste of money.
It really is. For CMT, it is. If you're a stroke patient, it'd be helpful, okay, but not for CMT. Yeah. What makes me so such a dynamic carbon AFO enthusiast is this slide right here. Here our expectations are wow. We get, with this design here, we get ankle stability, we get restoration of first rocker, second rocker, third rocker, and great ground reaction for restored balance. It does it all. And I love this design for patients who have advanced CMT, where they basically have no no functional strength in their feet and ankles and have poor balance. You'll see a lot of carbon AFOs, some are in the back of the leg and some are in the front of the leg. If they're in the back of the leg, they're good for foot drop. If they're in the front of the leg, they're also going to help you with that balance from the ground reaction and that propulsion because it's going to help restore heel rise. Yeah. Now, those braces you can't just get on Amazon and take out of the bag and put it in your shoe. They have to be customized. I mean, I always do custom foot orthotics with this design because people who have poor sensation, you have them stand on a hard carbon foot plate, recipe for disaster. A lot of people have painful calluses as it is. And really a custom foot orthotic is key to the whole thing. You'll have to machine the carbon foot plates. You're going to have to do extra padding where sometimes it'll hurt that sharp prominence of your shin on the front. And we want to off-weight the calluses and correct any varus and valgus. So really custom foot orthotics is a must for that style of AFO. Talk about confidence. When the foot hits the ground, if it's predictable and it's consistent, over time, you'll gain confidence. And that's true with anything, right? If your car started predictably and consistently, you'd have confidence in your car. If it didn't, you wouldn't, right? Same idea. Walking with AFOs, I see is like flying a plane on autopilot, right? I love this slide. Anybody like that movie? I love that movie. Anyway, the foot will always be in the right position at the right time, moving just the right amount, predictably and consistently. So walking with these AFOs, that's what gives us our confidence. If you never have to worry about where your foot is, you can just look where you're going and walk instead, confidence is restored. And that's fun. Another thing, there's a question I get a lot. Can I expect my AFOs to make me weaker? Well, wearing an AFO, put my muscles on vacation, I'm just going to get weaker and weaker. Good question, right? I get this question a lot. So there was a study that was published back in 2014 in Lower Extremity Review. We're still waiting for the follow-up study, which is a much larger cohort. This was a very short study, but and the second was an 8-week trial of 19 patients. It was on calf circumference. It started with this woman who was a marathon runner. When she wore the carbon AFOs, she said her calf got bigger, but then it broke. She went back to her old AFO. She said her calf got smaller, and nobody believed her, but she kept on saying it, and so they started a study about it, and that's what happened. So you do not get weaker with these carbon AFOs, but you may get weaker with the old-fashioned thermoplastic type, or those that immobilize your ankle. Because the carbon AFOs don't eliminate any motion, right? And it's rather instead they just control the motion. And all our muscles, all the way up the chain, and not just the muscles affected by CMT, those muscles that are synergistic muscles groups and antagonistic muscle groups that work with it, they all will get stronger because they're being used. And when we use a muscle, we lengthen it and we shorten it under load. If you immobilize it, then you're going to have tissue atrophy and it's just going to get smaller and smaller. Make sense? Yeah. So, and I find this consistently too. This is people do better. That guy Chuck I showed you earlier, I'm going to tell the story. I don't want to run out of time, but he came to my office the same time another guy from Bermuda came to my office. Same height, same age, same everything, except Chuck had been wearing the AFOs for 5 years, and this guy was getting it for the first time. We put the AFOs on both of them and they walk the same. Take the AFOs off, and Chuck, who had been wearing them for 5 years, walked better than the guy who hadn't been wearing them for 5 years. So you just plain walk better. You get better habits, you get better proximal strength. You can walk better if you're walking more normally. Make sense? Susan mentioned I was an identical twin. That is my mirror image identical twin brother Keith. And I always wondered, I see a lot of patients, and even if they're siblings, one can be severely affected, one can be minimally affected. And I said, geez, wouldn't it be interesting to see how different braces would affect somebody if I just had people that were really identical? And a little while ago at the CMT Center here in Boston, my wish came true. 2 identical twin brothers, right? Fred, the guy in the blue, I saw and I fit him, and he came to my office and he liked it. He made his brother come to the clinic and he came with him. But they're identical twins. Let me see. This is them walking. I mean, these guys are the same height, same age. Look, they're even walking in step over here, right? So identical, these guys. This is great fun for me. And watching them walk, they're identical. Same exact deficits. Now his brother, you'll see on the left, the guy in the white and check shirt, he's wearing the AFOs with the calf in the back. And I used the calf and the AFO in the front and did some training with Fred. And I want to show you the difference. They're going to start walking. I love this part. Now Fred's going slow. He doesn't want to feel bad for his brother right now. And in a minute, I'm going to ask them to increase their speed. Both have no foot drop. That works fine. But watch the propulsion and the balance that Fred gets now. And go.
Fred is the one on the check shirt.
No, Fred's in blue. He's still trying to go slow so his brother doesn't feel bad. Oh, wait, here we go. They're going to turn around. That's that physical therapist at the clinic, Katie. We ducked away. And now Fred's going to turn on the gas. And watch him. Now watch him turn around. Fred's standing in open space. No problem. His brother has to lean against the wall. And so it's a good story, but what can you expect from an AFO? Well, certain AFOs can do a lot more than others, okay? And this is what's possible. Fixed deformity is an issue though. Neither of those patients that I've shown, none of those patients I've showed so far have had a lot of fixed deformity. And job number one for people trying to treat CMT is to manage the weight line, which means you want to correct the deformity so that when you're standing, you're not standing on a deformed foot that's out of position so that you really can't do anything with it. And that's when surgery makes sense. Sometimes we can do some remodeling, but it's nice if you can get the foot straight. For those patients that don't want to have surgery and they still got a foot, there are some options that we can do. This guy here is a cop, actually. I just fit him last week because these are brand new videos. And you're going to watch him walk here and you'll see how much varus deformity he has in his foot. And look at his gait. Propulsive, foot drop.
What is that from? Is that advanced CMT or something?
See his CMT type X, yeah, 1X. He's not my worst patient. I've had some worse than that actually too. But he's just had a baby. His wife just had the baby, sorry. He wants to be functional with them. So we can't use those standard carbon AFOs on this patient. Unfortunately, the only way orthotically that I can get his weight line fixed or corrected is to do something that's more rigid. And so here he's going to come in some solid ankle carbon AFOs. But when you manage the weight line,
He's a young guy.
he is. Yeah. And strong. Oh my gosh, upper body. He's great guy too. But so again, and this is him walking without first rocker or second rocker, but he has third. Okay, that heel rise comes up with a solid ankle AFO. You don't get first rocker because the foot's stuck there. Second rocker, there's no motion of the leg available, but he gets that third rocker for propulsion, and that's why he's walking so fast. Okay, he's got that propulsive piece back.
Is it wrapping around his leg? The whole, this is the AFO.
I'll show you. This is it here. So these are some of the options that we do. And this is what he's in right here. This is a molded inner boot that basically wraps all the way around his leg. There's a huge space made in here for his leg to correct into. This is a compound strap that just cranks his ankle and pulls it this way into correction. This is really pushing the forefoot back the other way too. I use all my strength to derotate these patients, and I feel like I'm going to break their legs when I'm doing it. But once the brace is made, I can usually correct them a little bit more. 5 minutes left. Moving along, thank you. These are two other options. Very expensive option over there. And another option that has some motion, but they're all bigger, heavier, bulkier designs. I want to get to the gait training real quickly in 5 minutes. Do I need any special training? Imagine somebody gave you one of these. You need training to use it? Yeah, you do. I think I'm so funny. And I talk about, I say 2,000 years ago, there was this Roman general who taught his soldiers how to stand and how to walk. And you need to be trained with these AFOs. When you first put it on, people just walk the same way as they did before they got them because it's habit, it's familiar. Here, right, I teach people to stand like a soldier, like a parade rest. Okay, you don't want to stand like a gorilla. If you stand like a gorilla, you're using all these muscles, they're always turned on, you back aches, and even a gorilla, much stronger than a man, can only stand for a few minutes, then he has to move. But if you stand like this, you can stand for a long time. And when you stand, if you lean into the AFOs, you find that ground reaction, you find that coffee table, and you can stand for a long time. But it's the posture you want to use too. So gait training always starts with just standing. And then, like I said, this guarded gait pattern, so many CMT patients will walk, guarded. If you blindfolded me and had you walk across your backyard, right? I would walk like this. And that's how a lot of CMT patients walk. But that's not how that nurse walked, right? When the nurse walked, her pelvis is moving. I don't mind doing this. I'm very secure in my manhood, but you need pelvic motion. I'm all about the pelvic motion. And again, we get patients starting in the parallel bars and we get them moving again. I put them in the parallel bars, have them shift the weight over their foot. We start with one step, move 1 foot forward, they pull their pelvis over to that side and back and forth to that, learn how to move their pelvis again, and that's how we get people to learn how to use their muscles again well, it's gait training basically. And I don't know if you ever saw that movie Mad Men. She had a wiggle, that girl, and when she walked, and that was a wonderful thing. Pelvic motion is key. The best athletes can move their pelvis better than their competitors. So a baseball player can throw his pelvis way over there, catch a ball over here, then throw his pelvis way over there, and throw his upper body over there, better than his competitors. Pelvic motion is key to it all. And when we guard our pelvis, we just get weaker and slower, which leads to more weakness and being even slower. So pelvic motion is key. Men don't like to do it, but I always mention John Travolta. And this, see the paint can? When you remember that movie, Saturday Night Fever, he's walking down, his pelvis is moving down. It's good too. Elvis Presley, people like it when men move their pelvis too. We just think we have to walk like this. But pelvic motion, like I say, is key. We get the pelvis moving. And contralateral arm swing too is very important. Let me talk about that for a second. Chuck is very enthusiastic here walking. But arm swing, if you swing your arms when you walk, you lengthen all the muscles there to their optimal amount, so they have the most power to propel you into your next step. When you feel yourself getting tired, anybody in the room here right now, when you feel yourself walking getting tired, see if this doesn't work. Try to get up a little taller and straighter and swing your arms like a soldier. And you'll maximize the power that you have left to use. It works really well. And so basically what we can expect, this is my last slide, I think, but we want to eliminate foot drop. We want to eliminate ankle instability. We want to improve our balance. We want to increase our walking speed and decrease fatigue, restoration of heel rise, enhanced propulsion, improved confidence. Thank you. Because we want, when the foot hits the ground, for it to be predictable and consistent. No more downward gaze. And I think, oh, good, I did it. Thank you. So I know you have a, yes, please.
Does the nurse get a residual?
She doesn't know, but she's a love. She's a great person. Yeah. She let me take all the gait lab data on her and she was terrific. Yeah. Thank you. Yes.
What is the availability of all these AFOs around? Of course, we can get it with you, and
Yeah.
everything, but
Yeah, I'm here in
regular
Boston.
communities and everything.
Yes, these are readily available. And basically, even if you go to the CMTA website and stuff, you'll see, there's a lot of data on these types of AFOs for CMT patients. Just like you'll find the same, drugs not to take because they're neurotoxins for CMT, things that it's easy to find there. Yeah. And they're all covered by insurance.
Is that you?
It's off. You okay?
That's okay.
Can the propulsion be fixed if you have a fused ankle?
Unfortunately, no. Propulsion can't be fixed if you have a fused ankle because you can't get that plantar flexion. Now, you get part of it, just like that man you saw who was walking with the solid ankle AFOs. He had a propulsive gait pattern, but it wasn't smooth. He hit the ground, then it rocked forward and then rocked over his toe.
He doesn't want to wear them.
But that's where you are when you have a fused ankle, unfortunately.
Okay, thank you.
You're welcome.
Do you typically have to get bigger shoes when you get?
Always. I always say a size larger and a size wider. A shoe is meant to fit your foot and perhaps a sock. And we need a lot more real estate because we're putting in something much more substantial in there. So yeah, at least a size wider and larger.
Hey, Ken, can you hear me?
Is that? Oh, yes.
You mentioned that you have people that use AFOs and you said they walk better. One of the issues that I have is that when I put them on, I feel they help, but I feel when I take them off, it's as if I have forgotten how to walk completely. And I feel like that recovery phase is almost worse than not using them at all. And I just didn't know if you had any experience or tips or anything like that.
Well, I'm surprised how I get, you are one of many people who asked me this question. I have some patients that don't want to wear AFOs because they say they don't like the way they feel when they take them off. And the thing is, if you walk that much better with the AFOs, then they're doing a really good job. And that's to be expected is what I'm trying to say. The better the AFO is, then the worse you will walk with them when you take them off. Now, you're not going to get weaker because of them. You're not going to, it's not going to, speed up the progression of the disease process. But it's just really demonstrating how much you need the AFOs and how much of a benefit they are to you. There should be a significant difference when you take them off. If it was the same, you wouldn't need them. Yeah, I hope that is clear. All right.
Thank you so much. That was terrific.
Oh, thank you, Susan. Thank you all.